Thank you so much for having me. Thank you. A huge thank you to Dr. Pinn and Dr. Clayton and Dr. Temkin and the whole ORWH team. And thank you for listening to the end of this session, last but not least. And thank you to Dr. Giscombe and everybody else who've spoken before. My role today for the next few minutes is to amplify and connect as much as possible with respect to addressing chronic debilitating conditions for all women, with a special highlight for health equity. So structure, design, and inputs dictate output. Garbage in, garbage out, that famous equation, that's true. So you have to ask the right questions. You have to involve the right people at the table. You have to have the right structures and underlying platform to get the output that's most representative of the issue you're trying to improve. And asking the right questions is critical to developing the right solutions. And in this case, for women's health and for chronic debilitating conditions, it is essential to have this right structure and right questions being asked and the right people helping to ask these questions. You've heard today that we know that sex and gender, along with the intersectionality, and for disparities, this is crucial, intersectionality of race, ethnicity, SES, sexual identities, gender identities, stress, and many other socio and economic and political factors, so-called determinants of health, profoundly influence everything: cell physiology, metabolic syndromes, biologic function, symptoms, manifestation of diseases, response to treatments, and the list goes on. Now, back to the framing. You've seen a social ecological model. You've heard about the social determinants of health. But what's really important is that the social determinants of health actually advantage some populations and disadvantage others. So it's really important to understand that, and that they disadvantage women overall, but they also disadvantage substantially women of color. And it's not just about socioeconomic position or SES, because we know that women of color fare worse outcomes regardless of their socioeconomic status and their educational background. And systemic racism drives, it promulgates these social, economic, and political factors. It's not, I wouldn't call it a social determinant of health. I would call systemic racism as a root cause that drives things. And racism is indeed a risk factor. To highlight again, the population of the United States as of today, 50.6% are female. And since NIH is a federal structure, an entity, the research should really reflect 50% of the population, hopefully. The other thing is that 40% of that 50% are really non-white women. And so our demography, as it moves forward over the next few decades, is really evolving and increasing those proportions of non-white persons. It's also aging. And so chronic debilitating conditions are even more prominent and will be more prevalent and incident as we move forward in these decades. Again, to highlight the budget, the females comprise half of the population, but 11% of the NIH budget is spent on women's health research. And I love the Office of Women's Research and Women's Health. It has done extraordinary things. And what makes it even more extraordinary, its budget has remained almost flat since 2003, ranging from 41 million to 45 million a year. That's it. That's egregious and unacceptable and needs to be improved. So to give you a capture, like a snapshot, now again, this is not extensive. It's not meant to be completely exhaustive list, but disparities in chronic debilitating conditions are vast. We know about mental health. You heard that from Dr. Giscombe's lecture. Not only do women bear the brunt of mental health disparities in the US, but when you dig down deeper into the intersectionality, BIPOC women, women of color are, and minoritized groups are more likely to experience risk factors that cause mental health disorders. And when they get a mental health disorder, they're more likely to persist. And there's huge access issues with respect to access to care with mental health. Menopause. Black women experience more symptoms than white women, yet are substantially underrepresented in clinical trials. PCOS, polycystic ovarian syndrome. Black women have worse cardiometabolic profiles than white women, but we haven't studied it, barely. It's just the tip of the iceberg of the surface. Menstrual disorders, endometriosis. Black women's menstrual experiences are substantially understudied, and that also ties to fibroid research and heavy menstrual bleeding. The burden of autoimmune diseases, cardiovascular disease, diabetes, obesity, osteoarthritis, and other chronic debilitating conditions are shouldered by Black and Latina or Latinx women. In almost every study, women of color are underrepresented or not represented at all. For instance, osteoporosis, we use the T-score for diagnosing osteoporosis. Those T-score values are predicated on white women's measurements. So we actually don't know really how to apply T-scores to women of color. And there is really no research, very little research on that. And that promulgates, the conditions of osteoarthritis and furthermore, other conditions that are chronic and debilitating. Black and Latinx women have a higher risk of dementia and Alzheimer's associated diseases. Again, underfunded with respect to research. Preventive services, like was said before, I'm a former member of the United States Preventive Services Task Force, and preventive services can prevent chronic debilitating conditions. And there are substantial research grabs as part of that task force in the past 4 years. I can tell you it is painful to go through the research and really see the lack of participation of women of color and people of color in general in the large randomized controlled clinical trials. Lung cancer screening, as was highlighted earlier this morning, is one great example. There's also a lack of implementation and uptake in practice consistently across the country. So not everybody, regardless of where you live or what zip code you are, has the same access to all of the preventive services that are availed through the United States Preventive Services Task Force recommendation statements. And that includes things like use of preventive medications, which is really important in preventing breast cancer as one example, or access to genetic counseling, another really important preventive measure, behavioral counseling. There are also several other conditions that are severely underfunded by NIH research, yet impact so many of us. Violence against women, which has substantially increased during COVID-19 pandemic, impacts at least 1 in 3 women in their lifetime. And it promulgates and impacts substantially chronic debilitating conditions. An approach to better care for women experience violence, such as trauma-informed care, are substantially understudied. So I love this picture and this tree analogy. Now, the tree is organic, I agree, but I just use it as an example. This can be man-made, human-made structures, and not necessarily an organic structure. So if you look at the tree, and if you think of the tree as a policy, a practice, a treatment, a trial, or even the current NIH structure in which I have it labeled as such here, but it can apply to anything. It's bent towards one side. And that bending, right, advantages some people, populations, or types of research, and actively disadvantages some other types of research, such as in this case, women's health research, and pick your topic. It could be maternal mortality, cervical cancer mortality, or chronic debilitating conditions. And that is really, this is not equality. Equality means, okay, everybody's got access to writing an NIH grant or other research grant. Everybody's got the same size ladder and the same materials. But some people and some research topics and some investigators still can't reach the apple from the tree. And some are advantaged by that bending. So In a justice framework, a research justice framework and a health justice framework, we ask important question of why the heck is the tree bent in the first place? And so we have to seek to unbend the tree. And unbending the tree could mean a variety of things. And many have been stated, ideas, important concepts have been stated today. And so one idea is to really look at the NIH structure. It's a federated structure. How is it structured? And can you unbend that structure? Or can you modify it in some way? Can you improve pathways through which more women's health research can be done to really meet the needs of half of the population of this country? And NIH research should aim to protect all populations. And like Dr. Jenkins and many have said, we don't want to protect women away from research. We actually want to involve them in research and study the sex and gender differences and intersectionality so that we can actually improve women's health in many ways. So the structure and design of the research pipeline is fraught with inequities. And you really always, in order to find where the tree is bent or the processes are actively advantaging some and disadvantaging others, you want to look at every step of this. I'm an implementation scientist, so I like to geek out on process, and that's really important. You know, even at the funder level, the structure of NIH, there's bias, right? And that depends on what RFAs, what requests for proposals are set, what are the priorities of the director's office, what are the, where is the funding going, which institutes or ICs or centers get more money than others. The Office of Research in Women's Health, flat budget almost for the last, since 2003 is other examples, right? Who makes these funding opportunities? Who presents them? What expertise are represented in the staff throughout the ICs and centers, the institutes and centers? Who are the scientists? How are the pathways for more diverse scientists like myself to get people through the pipeline? What are the training pathways, the mentorship, the acceptance rate into certain faculty positions and schools, et cetera, et cetera? I think you get my picture, right? There are lots of opportunities for the tree to be bent, so to speak, in every step of the way towards the process of the output and impact of research. So the study protocols, study participants, research finding, dissemination, impact, there are a lot of areas of places where the tree is bent. For NIH specifically, most of women's health research, as was said earlier, is submitted and funded by RFAs. Those are temporary proposals with specific deadlines and actually have less time to turn them over. And usually that is advantaged by people in institutions with lots of resources, ability to stop everything what they're doing, to sacrifice work or home or personal issues, and actually just focus on getting a very fast deadline and a large grant out the door. That does not foster innovation or anything else. The other important point is the current siloed nature of NIH funding inhibits transdisciplinary and life course approaches required to advance women's health. So where is the woman in women's health research? Well, there's a female Waldo, to the best of my ability, in the lower right-hand corner. But you have to go to a specific institute with a grant. You can't go across 5 institutes, for example. So our current research design that NIH's structure creates does not align with NIH's mission to turn discovery into health, especially for women. The structure of NIH does not readily allow scientists to comprehensively and adequately address the transdisciplinary and nuanced sex and gender specific research needed to address the whole woman, and especially women of color. And it does not meet the true women's health clinical care needs, half of our population. So what we need now, a definition of chronic debilitating conditions, we don't have that. RCDC codes that accurately capture women's health conditions, including menopause, menstrual disorders, PCOS. Those are not right now existing. And menopause, as you all know, cannot be avoided in a woman's life. So it's astonishing that menopause is not an RCDC code, for example. An increase in workforce and a diverse workforce dedicated to women's health research, and that really needs to be addressed as we emerge from COVID-19's impact. Standing study sections that comprise women's health researchers, including OBGYN and other women's health research experts, and standing funding grant opportunities, such as a standing parent announcement in sex and gender research, to really promulgate more research that's needed to address things like chronic debilitating conditions. So creating a center or institute is important. I know this could be controversial with respect to funding. It's always a challenge. There are great examples on how the National Institute of Minority Health and Health Disparities graduated from an office to a center to an institute. NCATS reconvened and reconfigured with a new center, and such a structure is required if you're going to be a center or an institute. That helps confer grant-making authority, and it's grant-making authority that then promulgates and enhances increased women's health research, because it helps encourage more staff that are devoted to this. It helps encourage more diverse investigators that are devoted to this, and it helps increase more funding to this specific topic. And like I said, October 5th, 2021, Dr. Collins said he has doubled the number of women who are institute directors at the NIH. He has said he hopes his replacement would be a woman. There's an opportunity. So finally, in conclusion, instead of this is the road we want to go to and lift health for all women. Thank you so much.